Huh.
And since I've had this service for so long, I forgot all my.
And today will be, we're talking about outpatient shoulder replacement. It's a hot topic thing. My goal here would be to give you a little bit of an introduction about myself. For those of you who haven't met me and don't know anything about my background or training. So I'll introduce you to me. Then we'll kind of go through some basics of shoulder replacement. Then we'll talk about the topic at hand, which is really focusing on outpatient shoulder replacement, which we're doing more and more of here in East Tennessee and in Knoxville. And then toward the end, I'll save some time. And I have a patient of mine, Wayne, who has graciously agreed to join us and agreed to give us some of his input. And then at the end, we'll have some time for question and answer. It'll be relatively informal. I like to make this educational for you guys and not anything overly formal. And then the goal would be that you can ask me questions. You're welcome to ask Wayne questions too. The only disclaimer is he's from up north, so we can't. We got to watch what he says, you know. But he's been a good sport, so he's offered to join us, and we thank him for that. So, with no further ado, my name is Dr. Kennon, and I'm originally from a small town in Georgia. If any of you guys are, if anyone's ever seen the old sitcoms. From Dukes of Hazzard or In the Heat of the Night, or the new, some of the new TV shows, Vampire Diaries. All of those films and shows were filmed in my hometown here and that little square there in Covington, Georgia. So that's our claim to fame, very small town. In the way of training, you know, when I got done in Georgia, I spent a fair amount of time here in East Tennessee. So even though I was born and raised in Georgia, I spent a lot of time in East Tennessee before I came back. So in the way of education, I did my undergrad at Georgia Tech, did a lot of my medical training at the Medical College of Georgia. We're known for that little golf tournament out there once a year in Augusta that we just enjoyed last month, or sorry, this month, I guess, earlier this month, the Masters. And then after I finished down in Georgia and before coming back to East Tennessee, I did a fellowship up at the Mayo Clinic. Mayo Clinic's been ranked the #1 hospital in the nation several years running. I did a shoulder and elbow reconstruction fellowship. And so we took care of really complex shoulder replacement type problems and shoulder reconstruction problems. And then we also obviously worked with I worked with a lot of the head researchers and implant designers for a lot of these systems. And so that was a great experience. And I feel very blessed and very lucky to have had that opportunity to take that training, and then allows me to bring it back to East Tennessee. While we were up there, I published about 30 plus publications and presentations. Our work has been published at a national and international level. I authored a textbook. And we did almost 500 surgeries, and we've won awards for a lot of our research. And so, you know, having all that experience up there was really a game changer for me, and really inspired me to bring a lot of these advancements and technology back to East Tennessee when I came back. So this was a picture from us when we were up there in the cold snow of Minnesota. You can see that was our backyard down there on the right, where that was our, you know, looking out at fields and fields and fields of snow. And while we enjoyed the opportunity to train at Mayo Clinic and work there, despite the pretty pictures I'm showing here, we really were not snow people per se. And we were much happier to be able to see views like this and see beautiful East Tennessee in the fall time. So this was we knew we were coming back here, and so we're glad to be back. We've been back here for a couple of years now. And so getting to the topic at hand, you know, shoulder replacement is relatively new to be done in the outpatient setting over the past 5 or so years. For many years, when people had shoulder surgeries such as rotator cuff repairs or labral tears, a lot of the arthroscopic shoulder work we do has been outpatient for quite a while, probably 10, 15 years. Most of that's routinely done as an outpatient. And only recently have we started doing more outpatient shoulder replacement. So who gets a shoulder replacement? Well, for most people, it's arthritis. Our guest today, Wayne, will tell you that his looked much worse than this. He had a really bad shoulder, but it was end-stage arthritis. And the other big one is if you have a rotator cuff problem that can no longer be fixed with arthroscopic surgery, then a lot of those people end up with shoulder replacements. So that's kind of a high level. And then I certainly don't want to sell ourselves short here and tell everyone that they need surgery, because when you have end-stage arthritis or a rotator cuff tear or a problem, there are a lot of ways to treat these that are non-surgical. So I don't want to come on and let you guys know and present myself as such that every single patient needs a surgery, because a lot of people don't. And we are able to manage these things for quite a while with things like lifestyle changes and therapy and injections. And so when those things, unfortunately, sometimes they do run their course, and when you've exhausted those options, then possibly a shoulder replacement is good. It might be a good option for you. Interestingly, most people, almost everyone knows someone that's had a knee or a hip replacement. Shoulder is actually the third most common replacement done in the United States, and it's actually growing at a faster rate than knee replacement or hip replacement. So it's pretty interesting. A lot of people are not aware of that, but it's more common than you might think. And the reason that is because fundamentally we have a number of studies that could show you that it's just as safe and just as effective at relieving pain as a hip or knee replacement. And so depending on the study you look at, you have a 95 to 98% chance of having less pain with a shoulder replacement compared to preoperatively. So those are pretty good odds when you're talking about surgical intervention. And my goal always, this was one of our patients that gets out on the water on the boat a fair amount. And this was a picture of him back sailing, after having his shoulder replaced. And so the goal of all these kind of things is to get you back to enjoying your life, whether that's taking care of kids and grandkids or working in the yard, playing golf, whatever it is you enjoy. The purpose of doing shoulder replacement is such that you don't live in pain and you get back to enjoying the quality of life. And so when we run out of non-operative options, we do have pretty good options for you. So, where did this push come from? Where did the idea of doing outpatient shoulder replacement even come from? Well, like a lot of things, it started with the hip and knee guys. So total hips and total knees have been being done as an outpatient now for a good number of years. And as that has grown, now more insurance companies and also patients are starting to push for outpatient total knee and total hip. And now I don't do total knees and total hips, but we do have people that do that here at TOC. And so, much like that has grown in popularity along the way, has come total shoulder replacement as an outpatient. And fundamentally, when you think about the two procedures, shoulder arthroplasty or shoulder replacement has traditionally been thought of as a safer procedure. You have shorter hospital stays, fewer readmissions and complications, lower rates of blood transfusion, lower problems with death or having a blood clot or any of these really scary things we talk about. If you look at any of the studies, all the risk of those things are actually lower with shoulder replacement than they are hip and knee replacement. So it's generally thought of as a safer procedure than total knee or total hip procedures. And so it's reasonable to conclude that if knee and hip replacement's gone successfully in the outpatient setting, that total shoulder should be just as successful, if not more successful. And so we're just a little behind the times, I guess, in the shoulder world, but we're playing catch up, and I think we're making good strides. So what has brought about this change? Well, when you go back traditionally speaking, when you had a shoulder replacement, you were immobilized or in traction in the hospital for probably a week or a week and a half, and we had minimal pain control options. So that wasn't good. That didn't lend itself to being a short stay. So what's changed? Well, we've taken a lot of the techniques and we've made those better. We've also taken improvements in anesthesia and pain management. And with, when you combine better devices with better techniques by your surgeon, better anesthesia and better pain management, that has really created a safe and realistic option for most patients, or at least a lot of patients. And then on top of that, as I'm sure Wayne will attest to, there's an obvious appeal of recovering at home that we just think people do better, that you sleep better, you rest better, and you recover better when you're at home. And in addition to that, from a surgical standpoint, you have a lower risk of infection by getting back to your own home rather than staying in a hospital for days on end. beyond that, it's also a little more cost effective. And so you can trust me, me as the surgeon, I make the same amount of money no matter what. Okay. And so I have no win in the game by letting you go home the same day versus if you stay, overnight. But from a total perspective, as a patient, as insurance companies, you avoid the expense of a hospital stay. And the other thing that I tell people is that frankly, you're opening up a bed in the hospital for someone that probably needs it more than you do. And so I always think about, what if that were my family member, that maybe they were having a heart attack or something very serious. They were in a car accident. If they need to be in the hospital, I want to be sure that we have room in the hospital for those kind of people that absolutely need to stay. And so again, these are things that all kind of go into where did this come from. The other part, interestingly, is that part of this push, and the reason I decided to give this talk, was that during COVID, I started having patients come to me and ask me, well, Dr. Kennon, can I go home the same day? And I said, well, let's talk about it. And it turns out we have a pretty good system in place. And yeah, for some people, it's a very good option. I mean, it started because people were a little bit scared of staying in the hospital because of COVID. Now, I would tell you, I think that things are getting better in those regards. And I think that we have made big strides in the way of testing and just general vaccination and all the things that Park West Hospital is doing. I think that's improving our situation. But still, there are a lot of people that say, hey, if all things are equal, I'd rather recover at home. And so COVID, I do think this might be one of the positive things that came out of COVID, was more people entertaining the idea of getting home the same day. So along the way, what else has changed? Well, innovation. So these are some pictures of old shoulder replacements that I have from years ago that came into my clinic from other people. And if you look at this is kind of what shoulder replacement used to look like. Okay, this is something I lovingly refer to as heavy metal. Okay, there's a lot of metal in those shoulders. Okay, those prosthesis or those implants go almost all the way down the elbow. So those are big implants. And frankly, that's the way we used to do it because we didn't know any better. But as technology and innovation have gotten better, this is a picture of a replacement I did recently. It's blown up, so it looks kind of big, but in reality, that's probably 5 to 10% of the metal that we used to use in these implants. And so it's a much less invasive, kind of quicker recovery, less blood loss. There's a lot of advancements that have come along with the technology side of it. And then beyond that, this ingenuity's happened on the technology side. But the other part is that we're having to find ways to do this to meet patient demands. The demand is increasing about 10% per year each year. And so it's really a growing demand, and there's going to be more and more people needing this. And so we have to find ways to meet that demand. And one of those ways is by having better technology and better techniques. And so, along with the technique part, there's still surgeons in this town that their average shoulder replacement is a 3 or 4 or 5 hour surgery. And for me, it's about an hour, maybe an hour and a half, but depending on the complexity of the case. But it's no longer a 4 or 5 hour surgery that needs to be done in the hospital for days and days and days. And so we've really gotten better in terms of that. And less operative time means less anesthesia. And so people feel better, they wake up better, they're not as nauseous. The one other thing is that there is, along with the anesthesia advances, there are things called regional pain blocks, and those blocks really help patients in terms of pain control. And so that was something that before the pain control with a regional block, people had a hard time going home. But now with a regional block, people go home the same day oftentimes. And again, just like in a rotator cuff repair, a lot of people leave the same day and do really well. And so, along that, like I said, the efficiency of the hospital is improving. So in the 1990s, the average hospital stay after a shoulder replacement was about 10 days. Now it's about a day. Honestly, it's about 24 to 48 hours. And that study included complex revision surgery. So typically speaking, if you have a complex, if you've already had 6 surgeries on your shoulder, chances are you might not be the best candidate for an outpatient shoulder replacement. But my point is, even those complex ones are included in this study. And so this study, again, kind of overestimates it. But, nowadays, most uncomplicated shoulder replacement, you're either home the same day or within 24 hours. And so This has been a huge improvement and a huge advancement for people. Well, the question for patients then is, well, are people happy with this? And, how effective is it? Well, shoulder replacement in general does a great job at targeting pain and function loss for people that are suffering from it and they've lost their quality of life. And when we go in, we resurface the joint and we remove all the damaged areas and we replace it with this artificial joint. And once they're in place, we check the stability and the motion of the shoulder. And we think that we can do all this and still offer this just as safe and sound in an outpatient setting, because the intraoperative part is really no different. And so then this is our goal. This is one of my patients from a year or two ago. This was 6 weeks out from surgery. You can see she's got, you probably honestly can't tell which side we did. Her motion's almost symmetrical, and she recovered really nicely and said, I hadn't felt this good in years. I also include this picture down here on the right where you can see her incision. That's her incision at 6 weeks. Healed up nicely. You can barely see it. And, it's not a huge incision. Used to, again, the incision went halfway down the arm, and now we can do it through a pretty small incision that's relatively cosmetically appealing. And again, everybody's a little different with how they scar in and heal, but this is not a terribly uncommon result. And then, another important question, right? If I'm sitting out there in the audience taking my lunch break to listen to Dr. Kennon jabber on here, then I want to know, is it safe? And, is he just trying to push us out of the hospital, or, what's the story here? Well, there was a really kind of a landmark study done in 2018 that compared inpatient and outpatient surgery for total shoulder. They looked at how many people had complications, how many people were readmitted to the hospital, how many people ended up having a revision or a death or a big issue and a big setback. And I will tell you, these complication rates include every little thing that could go wrong. So, for instance, if you came back to see me two weeks out from surgery and you told me that you were a little constipated, or you had a little, some acid reflux or whatever, that's included in complications here. So I don't want you to think that the average real complication rate is 9%, because it's really not. The important part in terms of real complications is that if you look at outpatient and inpatient, the inpatient rate of complication is almost double what the outpatient rate is. And so not only is it safer, in a lot of respects, we actually realize that it may be better for patients to do some of this as an outpatient. And the number of people that presented back, had to go back to an emergency department or an urgent care facility or their regular doctor's office within 90 days was, again, less with the outpatient group than it was the inpatient group. And so, again, I think we have pretty good studies to show it's safe and effective. And along the effectiveness, I could list probably 10 surgery studies here that would show you that the results are about the same doing it as an inpatient or an outpatient. So needless to say, the outcomes are very comparable from a pain relief and a motion standpoint. So, well, again, we think it's a very effective thing. So the tricky part is who is the right candidate for this? And this is where I pride myself in being a team player and trying to partner with the patient and making sure that we have the right solution for you. So there's a lot of factors we consider. We look at your amount of independence you have before the shoulder replacement. Do you live by yourself? Are you a widow? Or do you have, I have patients that come in, they have a son and a daughter that live with them, and, and a husband or a wife, and they have their two cousins and their aunts that all live with them, or nearby. And so they have a ton of help. Other people don't, but that goes into our decision making. And then certainly the type of procedure and the medical history. And so who do I think would be a home run? Well, in my mind, a home run patient would be someone, probably less than 70 or 75, although we just recently did a very healthy lady that was 78, and she did wonderful. Again, she was healthier than some of the 50-year-olds I see. So she was very healthy, very minimal comorbidities or other illnesses. She had a very supportive family that was very capable and able-bodied, and her problem was pretty straightforward. She had arthritis that we could fix, and so we did her surgery in about an hour, and she went home later that afternoon and did wonderful. She was actually the one that kind of prompted part of this talk, because she asked me if she could talk to my other patients about this, because she said, I think everyone should do it. And so it was, just really kind of eye-opening for me that it probably has more to do with the patient than their exact age. Now, who probably isn't the one? Well, BMI stands for body mass index. And the picture on the right is not picking on anyone, but the idea behind this is that, if you have a fair amount of obesity and if you're pretty significantly overweight, you smoke 2 or 3 packs of cigarettes a day, you snore and you have sleep apnea, you've had multiple heart attacks, or your lungs don't work well, you're in a walker or wheelchair, or you don't have any help at home, and you fall a lot. If you put all those things together, that's probably not the best candidate for going home the same day. So those patients, I'm going to tell you, are going to stay with me in the hospital. Now, and then the tricky part is that there's probably a fine line of finding the balance between those. Wayne will tell you he's pretty healthy, but he's got a few medical problems, but they're not bad. He's got them well controlled. He worked very hard to get those under control before surgery. And then he got to go home the same day and was happy he did so. And so, again, we work through these things and we find the right solution. And so this is where education comes in, where I try to partner with you guys as the patients. We make sure we're on the same page. We've partnered together as a team. I've done all the preoperative planning. I get custom shoulders, either custom shoulders or a GPS navigated shoulder done on probably 99% of my patients. And so those patients I like to look into, and we already have a great plan before we get to the operating room. And so I think that saves us operating room time. And I think that everybody has at least to the best of my knowledge, we all have a good plan for how we're going to leave the hospital. So this was our goal. This is another patient of mine here. This was 6 weeks out. Let's see if we can get the video. So he had a custom shoulder replacement. He was 6 weeks out. He had no pain, and this is him lifting his shoulders out to the side. And then I'll show you a little external rotation, I think. Yep. So that was him at 6 weeks. Again, another guy doing well. And so I think finding the solution means you have to have the right surgeon in the right hospital. For me, it's all about finding the right patient with the right indication, the right anesthesia program, and the right surgeon. So if you find a good combination of that, I think you're in good hands. There's been several studies that have shown there's a value in shoulder specialists rather than the guys that only do some of these a year. There's been a direct correlation between shoulder volume and shoulder fellowship training and patient outcomes. We've showed that patients do better and they have less complications if you have a guy like that doing it. So what are some of my patients saying? And we're going to hear from Wayne. But most people are saying, most days I forget I've had it. It feels better than my other shoulder does. And I wish I'd done it sooner. People are back to reaching and lifting. I have patients that are back to riding bikes, playing golf, working out in the gym a little bit, just trying to stay healthy. And so most people are saying, look, I'm back to much better than I was before. I can take care of my activities of daily living. I can put deodorant on, I can shave, I can do things I wasn't able to do before. And I'm doing it a lot easier and having a lot less pain. So that's the bulk of it. This was one of my patients came in and I actually found this shirt on the internet to show you guys. The best endorsement was when they came in wearing this shirt. It said, never underestimate an old man with a bionic shoulder. And I thought that if you were willing to buy that shirt and wear that into my office, I wish I'd taken a picture of that day, but I feel like that's a testament that folks are doing well. So again, I think for the right patient, it's a game changer. So with no further ado, we're going to let Wayne join in on us here. Sloan, if you'll unmute Wayne and let him talk, and we're going to have Wayne just kind of tell us a little bit about his experience and his outpatient thing, and then we'll let us kind of ask some questions after that.
Hello?
Got it, Wayne. You're on.
I'm on. Oh, hi there. Okay, I don't see me. Do you guys see me?
Yes, they can see you in the box on the side.
Okay.
We'll
All
just
right.
put Kennon's pretty little picture up though. Or he can do this.
So go ahead. What do you want me to say?
So Wayne, Dr. Kennon, just give us a little bit of your idea. Tell me kind of what your expectations were before surgery and then kind of how that played out for you and getting to go home the same day, the kind of the benefits to that for you.
Well, I felt really confident in you for sure. That was one of the first things about it. It was long overdue. I should have had it done almost 10 years ago, but probably wouldn't have been as good. But I was fine with going home that day. With all the problems that we hear about in the hospitals, I don't want to be there and get any kind of other disease. So I had no problem going home. I had a good supportive wife at the time, so that she was able to help me with a lot of things that I couldn't do right away, like put a shirt on. There's other little things that, was very difficult to deal with, as far as, just not realizing that your hand is in a sling and you can't do everything that you want to do. But after like 2 or 3 weeks, I was a little bit more open air, and I was able to do a lot more things. Once I started PT, I think that was the most important part, because they're trying to keep me at a regular pace of improvement. And because I'm a little crazy maybe, and I like to push myself. And the guy that's taking care of me is doing a very good job, and they're very appreciative of how Dr. Kennon put together the prescription to getting it done. He says, because a lot of shoulder people don't tell the PT exactly how they want me to come around. So Jason from Blount Orthopedics, he was very happy and appreciative of the way Dr. Kennon, wrote it all out and prescribed how they want me to do it. So they're keeping me slow, and which is, I think, is really important. And even though it's not part of my regular life, I'm usually full speed all the way. So Dr. Kennon has told me that I can't do a full golf game. So although I want to.
We'll get you back to it, Wayne. Wayne, tell me
Well-
about your pain now. So, you're about 3 months out. Tell me about
Yeah.
your pain now compared to before surgery.
I don't have any pain at all. I mean, I just about do whatever I need to do. I mean, other than lifting things, sometimes I want to lift something and I shouldn't be doing it, because I do get a little bit of pain then. But I'm a little thick-headed, so,
Right.
oh yeah.
And did you feel like you rested better at home?
Oh yes, for sure. I mean, it was tough in the beginning, because there was pain. Because I also have my other shoulder that has to be done too. So eventually I'll get to that one. But yeah, because I couldn't even sleep it before the surgery. So now I'm able to get a full night's sleep. So
Wonderful. All
Yeah.
right. Well, so maybe we'll open up the panel. And again, Wayne, thanks for joining. I know you're working. I appreciate you joining. Patients may have some questions for you and for me. And honestly, Sloan, that was kind of, let me double check here. I think we got most of things done here.
Okay, perfect.
Um,
Does
I was
anyone
gonna
have
go-
any
so-
questions?
Go ahead.
Does anyone have any questions? You can either type them in the chat box, or if you want to, you can unmute yourself. Just be mindful of other people unmuting themselves as well, so we don't sound like a jumbled mess here. But if you do have a question, feel free to type it or unmute yourself for Dr. Kennon. While we're waiting on some questions to come in, just wanted to let you guys know, I will be sending out a follow-up email to this presentation. It will give you all the ways that you can schedule with Dr. Kennon, a way that you can get in contact with us if you come up with questions later. I can get those over to Dr. Kennon and send you his response. Trying to think of what else. Oh, and I will have the recorded presentation as well, for anybody who couldn't join today, or if you want to reference this back or show somebody anything at all, I will send that out as well. So if anyone has any questions, just going to give it a few more minutes. Thank you, Wayne, for, I muted him again. Thank you, Wayne, for joining us though.
Okay. Well, I'm glad I can help, So if anybody's got any questions, whatever they want to know, I mean,